This episode is sponsored by Dr. Chrono by EverHealth, the #1 mobile all-in-one EHR. Built specifically for medical practices, Dr. Chrono includes an integrated feature that powers a seamless payments acceptance experience. Dr. Chrono Payments offers multiple ways for patients to pay as well as insurance credit card processing. As a Dr. Chrono customer, you can easily activate our fully integrated payment solution that will streamline your cash flow and help you get paid anytime from anywhere. Deliver the best patient experience with a fast and easy way to collect payments. Visit drchrono.com/payments. That's drchrono.com/payments to learn more about Dr. Chrono today. Is there a DPC clinician, tech vendor, or industry champion that goes above and beyond to further elevate the DPC movement? Nominate them for a DPC Innovation Award to recognize them for creating traction, embracing innovation, and demonstrating commitment to the movement. DPC Innovation Award winners will be announced and honored at this year's Hint Summit, taking place in Denver, Colorado, September 27th through 28th. Nominate a DPC innovator at summit.hint.com, plus get $50 off your Hint Summit 2024 registration with promo code My DPC Story. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, patients pay their doctor a low monthly membership and, in return, build a lasting relationship with their doctor and have their doctor available at their fingertips.
What direct primary care or DPC means to me is being able to have this beautiful system outside of this quagmire of corporate medicine where I can take the time to establish a good relationship with all of my patients, where I can have trust go both ways, where they have time to learn about me, to trust me, and where I can have that trust reciprocated. I feel like DPC is a place where the doctor-patient partnership is prioritized over anything else compared to corporate medicine, where profits are prioritized over the doctor-patient relationship. And as a primary care doctor or as a family doctor, DPC for me is a chance to actually practice family medicine, to be that kind of Dr. Quinn medicine woman, whatever you want, to be that person that my patients can turn to for all the little things or for the big things, the scary things, the happy things happening in their life. I want to be that doctor, and DPC lets me be that doctor. I am Dr. Elizabeth Eaman at Oodle Family Medicine, and this is my DPC story.
Dr. Elizabeth Eaman received her BA from Wesleyan University in Connecticut in letters, a multidisciplinary major including history, philosophy, literature, and French. She did graduate work in forensic science at Wayne State University in Detroit before going back to school to pursue medicine. She received her medical degree from the University of Michigan Medical School and completed family medicine residency at the Tacoma Family Medicine Program in Washington State. After residency, she worked in Washington State's King County Community Health Centers for HealthPoint before spending 6 years with the University of Washington Neighborhood Clinics in Kent, Washington. After more than a decade working as an employee, she decided to start her own direct primary care practice, Oodle Family Medicine, where she could be the kind of doctor she always envisioned in medical school. She enjoys practicing the direct primary care model because she has an unfettered partnership with her patients, free from the burdens of the corporate medical business model and profit-minded, instead of patient-minded, insurance agencies of modern American medical culture. As the sole practitioner at Oodle Family Medicine, Dr. Eaman has been providing care for lesbian, bisexual, gay, queer, transgender, non-binary, gender-expansive, and gender-diverse patients her entire career. She is passionate about educating medical students, residents, and other physicians on how to provide appropriate care for this population. She is faculty with the University of Washington Medical School and works with students on their LGBTQ Pathways elective. When not in clinic, Dr. Eaman plays music with her bands, Rainbow City Band and Filthy Femcore. She also spends her free time with her animals, Archie the horse, Wally the dog, and Henry the cat. Welcome to the podcast, Dr. Eaman.
Thank you so much. I'm really happy to be here.
I remember when I was sitting in the audience when Dr. Sharon George and Dr. Linnea Meyer at the last Nuts and Bolts that we had in person were giving their presentation, and on the screen you came. And so if anybody has not seen that presentation, I definitely would encourage you to visit Dr. Eaman's blog on the website where you can see the whole presentation. But during that presentation, Dr. George was talking about how you take care of transgender patients that have been abandoned by their families. And that just stuck out to me. And so I'm really excited to talk with you today, because not only did it sadden me to hear that, but it also opened my ears to wanting to know more about you, this doctor taking care of people who are considered marginalized. And so can you give us an introduction as to the type of medicine you practice to take care of people who may be marginalized in the LGBTQ community?
I would say I have a very strong focus in my practice on gender affirming and queer medicine. An independent physician who is not in that, not neck deep in the academic world, not in a multi-specialty clinic, not working with a dozen other doctors, not seeing 3,000 patients on their panel. So I've given lectures for what's called the WWAMI Network, which is affiliated with the University of Washington, but it's a family medicine network, including Washington, Wyoming, Alaska, Montana, and Idaho. So I've kind of put my name out there as somebody who can do this. So I do get emails and messages from people who aren't comfortable asking me, can you help me with this? Or can you see this person? I encourage them to send them to me, but then I also try to give them some avenues to learn how to do it themselves.
How do you keep up with standards of care when it comes to the LGBTQ community?
It's an area of focus, I would say, but not a specialty. So, we see family physicians do a lot of OB and gynecological care, for example, and deliver babies. And that can be an area of focus for them, but they haven't specialized in OB. So, that's one of the reasons I picked family medicine, is because I get to do a little bit of everything. And that's why my undergraduate degree was history, philosophy, literature, and French. I wanted a little bit of everything. The thing with family medicine and primary care is that we become kind of a jack of all trades. And one of the major skills of being in, primary care is that you have to be able to teach yourself and stay up to date on the current recommendations on any clinical condition. And so I try to tell doctors, this is like if you got new diabetic recommendations, new recommendations on metabolic syndrome and weight management. We're talking about insulin resistance a lot more. And so there's a lot of opportunities to kind of grow your knowledge. And I think there's some providers who just, that they don't have the bandwidth for it. And they don't have, quote unquote, enough patients to dedicate their time to do that. And that's unfortunate for their patients who identify as gender nonconforming, because they don't get to have a doctor who cares enough about their condition. So I see a lot of patients who kind of come from that kind of system. And you see that in a lot of different areas. You see that in, like I said, diabetes. I might see somebody who comes in on this really strange diabetic regimen that may have been what was cool when I was in med school, but we've learned a lot since then. And, be too strictly restricting their glucose and causing hypoglycemia, or people just throwing on statins all the time, even though it's questionable whether they're effective as primary prevention, or same thing for aspirin. So treating gender affirming care as this really subspecialized, unique health issue, I think is part of the problem. I think it's just another thing our patients deal with, and we need to meet them where they're at. And then also the family docs, since we're the people who kind of know what humility is. I know I don't sound very humble when I say that, but we're the people who understand that concept. We're also the people who are good advocates. And I couldn't pick a specialty that didn't have advocacy somehow involved with my family background.
As a DPC movement, we have more time with our patients to make sure that we're giving the most up-to-date care, which is one of the powers, the great powers of this movement.
you totally were spot on. Is like with DPC, we have so much more time to be better doctors to provide quality care. And what do we mean by, we say that all the time, oh, it's better quality care. And what do we mean by quality care? Well, we mean like we have a trusting relationship with our patients. It means we have time to do research on their individual conditions. So if somebody's in DPC practice and they have a patient who establishes with them who says, I'm intersex and I had ambiguous genitalia, and as I grew up, I identified female and I had to have surgery and so on and so forth. In the old practice, you had 7 minutes to kind of figure it out, right? Like what probably would refer this patient to an endocrinologist or that kind of thing. But in my practice, I have time to say, okay, well, tell me more about your process. Tell me what happened. And then you can get records if you need to. I have a patient who doesn't know what anatomy they have because they were given surgery when they were quite young because they were intersex. And they're not sure if there's a prostate or some residual sex organs at all. So we have to kind of dig that stuff up. And I can teach myself and learn about it because as a family doctor, that's the skill that I learned, was to know where to look, how to research, and how to catch myself up on medical conditions my patients have to provide them good primary and preventative care. If they have a hole in their heart, I will refer them to a cardiologist. That's something I can read up on and learn about, but that's not something that's in my kind of scope of practice. But in terms of, do I need to screen them for prostate cancer or cervical cancer? That is in my scope of practice. And I need to be in a place where I have trust with my patients and we can figure out what they need. I think any DPC doc would be in a good position to be able to provide adequate care for gender nonconforming and patients who are not neurotypical or who have unusual family structures or housing or job instability, because we can have that kind of trust where we can address the things that are very, very difficult to address in a 7-minute office visit. When we talk about what DPC is and why it's so amazing is that it allows you to spend time with your patients, get to know your patients, and they learn to trust you, but you also learn to trust them. Like it goes both ways. So with the current medical model where you have this very limited time, and not only is your time in that room with that patient so limited, but you have 100 things going on behind the scenes that you're having to juggle, billing and coding and covering for other doctors. And then there's multiple other patients sitting in there. And then so-and-so just walked in and, it's just very hectic. You may find it easier to kind of put on a happy face or kind of be yourself so that the patient maybe trusts you easier, but it's hard to trust your patient if you don't have much time to get to know them. And so so trusting and believing are different things, right? So, when my patient comes in and says something, I tend to believe them. And then as the relationship develops, this sense of trust happens. And if I have certain patients, like if they text me and say, this is an emergency, I will drop everything and be like, okay, I know this patient, I know them well. They do not use these terms lightly. We need to figure this out right away. It's a mutual trust. It's a partnership.
As I think about my own practice right now, there are patients where I feel I have that partnership, but those are the patients who have spent time, like you're saying. And
you also have to remember that patients come in, and if they've had negative experiences where they've had people who didn't believe them, they're on guard already. So kind of getting through that and getting to the point of trust is going to take extra time and extra work. And I have that time. I have the ability to slow down and say, I know you've had some negative experiences in the past. Let's talk about that. If you're comfortable talking about that, tell me where you're at. There's no judgment here. But when you're really in a time crunch and you're limited in your resources and you're already feeling run down because you've already seen 22 people that day and have had to make decisions to, oh, well, I know you're depressed and you have knee pain, but we'll talk about your knee pain today and you come back for your depression, right? You do that all day. That's just like the death by paper cuts. Those are things where you're like, I could do this, but I don't have the tools I need to do it. They call that moral injury. But, when you have the time to be able to kind of help work through those barriers with patients, it makes the patient-physician relationship so much more rewarding for both parties.
Stay with us. We'll be right back. Thank you to Spruce Health for supporting the My DPC Story podcast. The ways we communicate have changed dramatically over the past decades, but technology and tools in healthcare have not kept pace. Patients want more access and digital convenience, as well as the ability to text their care teams. Care teams are inundated with more communication and rising expectations, but are still using tools and technology stuck in prior decades. Spruce Health created a solution for the tech-forward DPC practice by creating a communication product designed to serve both the patient and the doctor through intuitive HIPAA-compliant workflows, tagging, scheduled messages, and triage templates ready for use, whether you're on your phone or in the exam room. New users get 20% off for the first 12 months of a paid plan with code MARYAL20. That's MARYAL20. So check out Spruce Health today at sprucehealth.com or check out the link in the show notes. Now, here's a question because I'm reflecting on my own very limited history when it comes to taking care of a person who is in the LGBTQ community. In an effort to try to be as inclusive as I possibly can, I do find myself almost hesitating sometimes because I'm so fearful of making a mistake with regards to using the correct pronouns, using the correct name, talking about a person's history. My question to you is, how would you advise other physicians in terms of how to handle a situation where they might be wanting to do the right thing for and by the patient, but they come across as hesitant or fearful because they don't want to offend?
If you're somebody who wants to say the right thing and you're worried about messing up, you're already in a good place because that means you're aware of what you're saying. So say what you feel is right and then check in. And if it doesn't feel right, or if the patient corrects you, actually, I use they, them pronouns, then be in that place, be humble, take that humility to say, thank you for the correction, and be graceful about it. Be open to making mistakes and embrace your mistakes as a way to improve your communication. It's always an opportunity. Making a mistake, I mean, people talk about that all the time. Making a mistake is always an opportunity, right? You don't succeed without mistakes. You fall down 500 times, you get up 501. But when it comes to things like misgendering or using the wrong terms or not understanding something about somebody's identity, people who are caring and compassionate get really scared because we really care and we're really compassionate and we don't want to hurt those other people.
Yeah.
Right? And so you don't want to say the wrong thing. And then it kind of spirals like, well, then what do I say? And then they can see that you're uncomfortable. So you need to learn how to be okay being uncomfortable and that it's okay, that discomfort makes you open to being more compassionate. When people are really comfortable with being closed-minded, those are the people that are causing the damage. Those are the people who say, well, I see an Adam's apple, I'm going to call you he. Those are the people that are going to really, really hurt their patients. But the people who are open to that discomfort are the ones who are going to do the right thing. So the fact that you feel like a little nervous and a little uncomfortable, you're already showing that kind of compassion. So you're there. You just forgive yourself already and keep moving forward. One other thing that I think is a kind of a requirement for family medicine is that you need to be okay not fixing everything. I think, especially for some people who go into internal medicine or people who want the answer and they want to fix it.
Yeah.
Patient comes in and they were misgendered by their surgeon and they're crying, and what that patient needs from us in that moment is just to sit there with them.
Yeah.
And to say, and to be representative of this system that just hurt them and just be like, you know what, I'm in that system too. And I'm with you and I'm not going to hurt you and it's going to be okay. And that's really valuable. And I think that took a while for me to figure out in my career, is that some of the most complex patients we see, they don't necessarily want all of their problems fixed.
Yeah.
They just want a safe place to go and be able to talk about them.
Yeah. Do you find that because, like you said, you've been presenting in WWAMI and you've put your name out there as someone who is confident and is able to give the time to patients who are in the LGBTQ community, do you find that patients are sharing in their social networks that you and your clinic are a safe place for them to come?
Oh, yeah. I mean, I opened in January of 2018. And when I opened, I had mostly transgender, gay and lesbian patients. And I had a few cis heterosexual families as well from my old practice that wanted to stay with me. And since then, I've really only grown by word of mouth. And the trans community is pretty tight knit. And they have good resources, they have Facebook groups and chat rooms and, a lot of online resources currently during the pandemic. Obviously, you can't meet in person, but yeah, I really, really nurture that safe space. When I onboard a new patient, I ask them their gender identity, their preferred name. And if the question makes them seem uncomfortable, I tell them why I ask. And then I also clarify, I see many people who are transgender or non-binary or gender non-conforming in my clinic. And if that makes you really uncomfortable, this might not be a good fit for you as a practice. And I've actually never had a patient leave because of that. So that's the top priority, is that my practice is a safe place for my gender non-conforming patients.
I love that you have created a safe space for the LGBTQ community to come, and that your practice is growing because of that. I think if anything is gleaned from this podcast, I think just knowing where one can increase their knowledge or just be a little bit more comfortable discussing gender identity and preferred name. Those are great starting points for a person who does not have a strong base of knowledge in LGBTQ medicine to start with. So I want to pull back, and you opened in January 2018. I would love to hear how you came to even learn about the DPC movement.
Yeah. So it's kind of a circuitous route. I, just like my path to medicine, it wasn't very straightforward. I was in my old practice. I worked for a large academic center, and I really loved my clinic. I loved my patients there, and I loved my colleagues, my coworkers, my MAs, the front office staff. I mean, it was a really, really great workplace, but the corporate medical care environment was toxic. And it took me a while to realize that it was not me, it was them. I really struggled. So in my old practice, I was assigned patients. So I had several thousand patients assigned to me who I was quote unquote responsible for, maybe 1,000 who I would see within a year. And I was encouraged to see as many as I could manage in a day. And if I saw less than what my employer felt was lucrative, I would be notified, that I wasn't seeing as many patients as they wanted me to see. And for a long time, they really based pay on what's called RVUs, which is basically assigning financial value to an office visit, which just by itself makes me a little disturbed because these are humans we're talking about. But yeah, so it just kind of assigns each visit this like financial marker, like this visit is this much and this visit is that much. And we were encouraged to get a certain RVU number, and then we'd get paid bonuses above that. And then at some point, shortly after the Affordable Care Act was enacted, I think the hearts of the folks who designed this were kind of in the right place. They wanted to focus more on quality as opposed to quantity of care. So they started looking at health measures like blood pressure and blood glucose averages, and started paying providers based on those results. Now, those results were easy to measure and track in an electronic medical record system, which is one of the reasons why electronic medical record systems became pretty much a requirement, to be accepting of the Affordable Care Act and like medical home models and such. But they were these easily kind of searchable items, right? This number in the chart. And then they started paying us those bonuses, which kind of were a large portion of our pay, based on how well we met those numbers. So how well were our patients' blood pressure controlled? How well were we doing on terms of their diabetic care? And it broke me. It totally broke me. I had a patient who was a African-American transgender sex worker who had out of control diabetes and multiple other risk factors and health issues, mental health, was on disability. And every time I saw her in clinic, I would get a ding from my administrators because her blood glucose was above the number that they're looking for. And if she was really struggling and I had to see her 3 times in a month, I'd get 3 dings that month. And I was being financially penalized for seeing sick people and taking good care of them. And as I tried to explain this, I joined some committees and I tried to work within the system to try and see if we could improve this. I was really shut down repeatedly. There was a lot of buy-in onto these kind of numbers being an actual measure of quality, which I very strongly believe is not true. And I would get a report every month. Every month we'd get a little report. How many of our patients were above this number and how many of our patients who are marked female on the chart, had pap smears, regardless of what their anatomy was. I had a number of transgender patients, and it would be green if we made those numbers and it would be red if we didn't. And I would get these like long red bars on my report. And, I'd break it down and look, well, who am I not screening? And it was not relevant to patient care at all. So that really, really frustrated me. And it just made me realize that the system I was working in was completely broken. There were days I would say a light day for me was 18 patients. That was 9 in the morning and 9 in the afternoon. That was if I had a lot of procedures. I did colposcopy, which takes longer and such. And a busy day would be 26. Some providers had busier days than that. And I would look at my schedule and I would see, okay, I have 4 patients that hour. There's no way I can give them the time that they need. So I would have to look and I would have to make the conscious decision to be a bad doctor, what I thought was a bad doctor, in order to get through that hour. Because there was no way I could sit and listen compassionately to 4 people in an hour and come up with a diagnosis and a plan and order whatever prescriptions they may need or referrals they may need, or make follow-up phone calls and cover for the other 11 doctors in the office I might be covering for. And I remember being so angry about that and feeling really trapped in that system. So that's the bad side of it. That's what drove me to look for alternatives. I really just thought about quitting altogether, but obviously I did liberal arts as an undergrad, and then I went back to pre-medical requirements and then into med school, and I'd really sacrificed my 20s and my 30s to this career. And so it was really daunting to think I would just abandon it, right? I still have just mountains of student debt. And I stumbled across a video, I think it was a TED Talk, and I think one of my exes actually stumbled across it for me and asked me to watch it. And this woman was talking about how she doesn't take insurance and it allows her to do whatever she wants in her clinic. And I kind of rolled my eyes. I was like, that's too good to be true. That's not real. And I went, she had a website. This is Pamela Weibel, who is pretty well known in the DPC community. And she has kind of her own proprietary version of DPC called the Ideal Medical Practice. Is that sound right? Yeah. So I went to her website and I read a little more, and it was pretty interesting. And I kind of looked up some ideal medical practice, see if there's any near me. And I found one. And he was a doctor who focused on, his name was Dr. Stewart, and he focused on metabolic care. And I asked him, I said, can I come shadow you in your clinic? Because this sounds interesting, but I really want to know, like, is this possible? Can we really do something like this? And I went and I saw him, and he worked with his wife was his front office and back office staff. And he had a clinic out of his home, which was amazing. And I spent the day with him, and I was just enamored. I thought this is exactly what I want to do. And he's the one who told me about direct primary care. So when he asked me what I was looking for, and I was telling him what I was hoping for, he said, you need to look into DPC. So he directed me to the American Academy of Family Physicians, had a interest group about DPC, which was kind of an online forum. I went on there. I think this was probably 2015, 2014. It was a while ago. And I went on there and I was reading all the posts and doing my research. And then I reached out to one of the docs there, Julie Gunther, who is actually the president of the Direct Primary Care Alliance now, and asked her a bunch of questions and ended up going to a conference, and kind of the rest is history. I learned about DPC. I learned that it was doable, and I made a 2-year plan. So in 2016, I kind of sat down and decided this is what I wanted to do, and worked on kind of developing my plan over the next 2 years. I had to give, I think it was 6 months notice at my job. So I made sure I give them plenty of notice. And in October of 2017, I said goodbye to corporate medicine. And January of 2018, I opened up my DPC.
Liz, for the listener who may have not visited your website yet, can you please share about the namesake of your clinic? Stay with us. We'll be right back. Have you tried an AI scribe in your clinic? Well, I've tried so many, and I can say Heidi Health is the best AI scribe I have come across thus far. With Heidi Health, I can create unlimited customizable templates for my notes to help me truly cut down on the time I'm spending charting. Template for pediatric well child check? Done. Template for weight loss management? Done. Some of my favorite things I've built into my AI template, beyond the general soap note, are having a list of actionables for our team to take after a patient visit, having the diagnoses listed, and creating an after-visit summary for our patients. Not only have I found Heidi Health to be the most helpful, customizable AI scribe so far, it's also more affordable than most out there. So try Heidi Health today and see how you can harness the power of an AI scribe for your practice. To get an entire month of Heidi Pro free, go to the homepage of mydpcstory.com and click on the Heidi Health ad.
Yeah, so I chose to do DPC in 2016 is when I decided to buckle down and make it happen. And that was the year my mother passed away after I had made the decision. So I'm not quite sure how much she understood at the end there, but I did tell her about what I was doing. So I don't know, 6 months to a year before I was opening, I was trying to come up with a name for the practice so I could start, working on the website. And I was really struggling because I had a lot of interests, I could throw in there. Like I like horses. So maybe it would be like horseshoe PCP. I don't know. So I was kind of tossing around these ideas. And a friend of mine knew about my mom's Hebrew name and just kind of said it out loud. Well, what about Oodle? Because I was thinking, maybe I could name it after my mom. And she said, well, what about Oodle? And so the story is, why Oodle? My mom is Jewish, and her first name was Alan, and her Hebrew name was Oodle or Oodle. And as with, all things Hebrew, right, there's not a specific correct or incorrect way to spell it, but generally we used Oodle. And as she was growing up, it was kind of a joke a little bit, Oodle. She kind of got made fun of a little bit. But as she grew, she had a great sense of humor and she accepted it. So when I got married, we had signed a marriage ketubah and used her Hebrew name, and it was Oodle was on there. And so we decided, to name the practice Oodle after my mother because the name was great. I wanted to honor her, and I felt it made me feel closer to her. It was a fun name. It certainly is memorable. We do have to repeat it a lot when we talk to people on the phone. And my mom was amazing. So it's such an honor to have my practice named after her. She was a very big part of the second wave of feminism. She was very active in all of her communities. So in the Detroit area, and then again in the suburbs of Detroit, as she was aging, she had this drive that was pretty unbelievable. And she'd work pro bono. She would open up her heart to people. She believed in the best. And she did a lot of difficult work. She worked on a lot of sexual harassment cases and sexual assault, supporting women who were fired or abused by their employers because of their gender. And she still maintained this just wicked sense of humor. She was always very funny. And I do like to think that I have some of her traits where I can do a lot of serious things, but I don't have to take them all seriously all the time. And I appreciate that part of her that lives on in me. So it's kind of a roundabout story, but that's where Oodle came from. I do like to direct people to my website. My sister is a journalist, and my sister and myself and my brother, really the whole family contributed to writing her obituary. But the real meaty parts of it were really written by my sister, who's an amazing writer. And she tells the story of who my mom was, right down to her love of dance and music, to her activism, and how she tried the first sexual harassment trial in the United States. So if you haven't seen it on my website, oodlemd.com, you should check it out. It's pretty impressive.
You guys absolutely did an excellent job. Having lost my own dad 7 years ago, the fact that you're honoring your mom in such a beautiful way and a permanent way, I think it's amazing. Like occasionally I'll Google my dad's obituary just to see him wherever I am. And you can do the same with your mom, but with a much more in-depth, beautiful story. When your sister talks about oh goodness, it was where Lily Tomlin and Gloria Steinem were at was it a rally? Yeah. Things like that, you could just envision them, right? So, and envision your mom there. So
yeah, it was a rally to help defend two women who killed their rapists in self-defense. And Gloria Steinem and Lily Tomlin were there. And then one of the original Supremes was there and sang "I Am Woman" by Helen Reddy. So her name was Florence Ballard. Yeah. And actually one of the last things my mom did before she kind of lost consciousness and passed away was we sang "I Am Woman" at her bedside. It was pretty meaningful. So, but yeah, if you want to learn more about that and some of her other kind of big jobs with the second wave of feminism in the Detroit area, there's a movie called Passing the Torch. It's about feminism in the state of Michigan specifically. But yeah, no, my mom was incredible. She wasn't perfect, right? Who's perfect? But for me, she was a very good role model, and she was my mom. So she was goofy, and we had a good time. And I'm the youngest by quite a bit of three. So when I was 10, she divorced my father, and my sister and brother were off at college. My sister had just left for college. My brother had been there for a couple of years by then. And so it just kind of became the two of us. So we were like partners in crime for quite some time, pretty much until I ran off to residency. So we had a good time.
I think that is so wonderful that you celebrate your mom. And I love that you told her about it, even though, like you said, you don't know if she heard. But I am a firm believer in that, even if they're physically not here, she knows what you're doing even now. Like, that's just how I believe. That's how I also cope with my own father not seeing my future in DPC or seeing grandsons grow up, right? So I just think that that's a beautiful tribute.
I want to bring up my dad too, because he was a criminal defense attorney before he retired. And he definitely stood up for the underdog. So and his health has been pretty poor this past year, and he's having some issues with his speech, but the Black Lives Matter movement has really resonated with him. And as a criminal defense attorney who has had to stand up for people who have been railroaded by the justice system, he's been instrumental as well in helping me recognize that serving people who are marginalized, standing with them, next to them, is its own reward. Like, you don't have to. I think a lot of people don't realize someone like a criminal defense attorney, they oh yeah, he's defending murderers and people who ran over somebody or drug dealers, but really not everybody who's accused of a crime is a criminal. And he took all of that in stride. Like, he didn't let it get to him. He did what he thought was right for his clients every time. He was amazing at it. And so when I started seeing transgender patients and doing gender affirming care in residency, and I had faculty who weren't there with me yet. I think a majority of them, by the time I graduated, had met me there. I kept plowing forward. I kept saying, I know what I'm doing is right, and you guys need to catch up. This is what needs to be done. We need to believe people when they tell us they're gender dysphoric. Like, yes, people need counseling support. Everybody needs counseling support, but we need to believe our patients. They don't, why should they have to jump through 1,000 hoops to prove to us they're having chest dysphoria or genital dysphoria because they were born in the wrong body? Anyway, so I think my dad really kind of plays out in my approach there too. It helps me be more duck-like, kind of let things roll off when I know I'm doing the right thing. Kind of gives me that inner power to keep doing the right thing.
Patients you've had who've experienced marginalization of any sort when it comes to their own healthcare, what are some ways that you've seen their healthcare suffer in terms of chronic care conditions or mental health?
All of it. I mean, all of it. I'm not the leading expert on minority stress, but I mean, it's well established and well known that minorities, whether it be racial, ethnic, gender, sexual minorities, deal with stress on a level that has a huge impact on their health. People won't seek out care for health conditions because they've had negative experiences in the past. Because I recently had a patient who was suicidal and who called 911. And the local police were actually very sensitive about using the proper pronouns. The patient was transgender female, and presents female, but still has enough male characteristics that will get misgendered, which is very dysphoric. And the dysphoria is what led the patient to feel such intense negative emotions to lead them to consider ending their own lives. They end up in the ER, and ER staff misgender them to their face after being corrected multiple times. So now next time this patient needs help, are they going to want to go to the ER, or are they going to feel an additional sense of hopelessness because last time it just piled on for them? I mean, that's just one thing, right? But it happens in all sorts of all realms. I mean, I remember being in med school and we used to have this LGBT, but it was really just LG panel where other med students who identified as lesbian or gay would sit at a conference table on a stage in front of as many people from the med school as wanted to come, right? So up to 4 classes of medical students, usually just the first 2 because the last 2 were busy on their rotations, but whoever wanted to come could come. And then they could ask like any question they want to. There was nothing that we didn't, that there was no stupid question. And it allowed people to really just be able to explore their preconceived notions, their prejudices in a non-judgmental way and learn about their own biases. I mean, I remember one of the questions was like, well, how do you feel now that you're never going to have kids? And those of us on the panel were just kind of looked at each other and we're like, oh, that's so cute. Okay, so here's the thing. You can still have children. So when people go into the doctor's office and the doctor has all these prejudices, right? And they already are vulnerable because they're sick and they're at the doctor's. Sometimes it doesn't take a lot to drive them away. And so because of those kinds of things, we do see sometimes increased risk of certain cancers in, like, for example, an increased risk of breast cancer in the lesbian population, because going in to get a breast exam from a doctor is a little scarier. I have a number of lesbian patients who have these experiences where they were asked if they were sexually active. They say yes. Okay, well, are you taking birth control? No. They don't ask, are you sexually active with men or women or both? Now I think most med students are taught that language, but then they start getting judged. Well, why aren't you on? Do you want to get pregnant? And then it's on the vulnerable party, the patient, to then educate the provider, which is a really tough position to be in for anyone. But it's kind of American healthcare. A lot of people have to do that. I mean, people with chronic pain have to do it. People with rare illnesses or genetic illnesses will often have to educate their providers on what they have and what's going on. And queer people have to do that too. So it's not easy. There's a lot of other health disparities we see. I mean, obviously in the trans community, we see more incidents of violence. In the LGBTQ community, we see homelessness, we see job instability, we see housing instability. We've made progress in the last 40 years, but there's still a lot of discrimination that leads to health disparities.
When you look at your clinic and your community, have you paired up with certain people that you trust to give your patients the same quality medicine that you give them? And how did you build that community?
Yeah. Well, I'd say a majority of my career out of residency, I spent working for an academic health center. And we would be introduced to new specialists in the community. They'd come and at lunch and give us a lecture on something, or just come bring sandwiches and just meet and greet. Here's your new ENT docs. And I would ask them, I'd say, okay, I have a large transgender patient population. Are you comfortable seeing transgender patients? Oh, you're an ENT. Do you do tracheal shaves for gender affirming surgery? Or do you do gender affirming, facial feminization surgeries? I talked to a colorectal doc and I was like, if I do a, anal pap smear in one of my HIV positive men who have sex with men and it comes back positive for HPV and dysplasia, would you be a good person for them to follow up with? And through asking these questions about these are the things my patients need as LGBTQ patients, you get a good sense of the specialist's kind of comfort level. I mean, people use their body language to kind of let you know what they think. If they're stammering and they kind of step back a little bit, then, maybe they're not the first choice for me. And I had a few specialists who just really leaned in and they're like, absolutely, send these people to me. So I kept a list of those folks. And now that I'm in independent practice, I don't have to refer in network. There's a lot of pressure when you work in a healthcare system to refer within that same healthcare system, regardless of whether it's an HMO or independent health organization. There's still a lot of pressure to refer within because of obviously the financial gains for the institution. So I keep those lists and I still refer to those same people. I mean, there's a colorectal surgeon who I love, and one of my LGBT patients needs something, or one of my straight cis patients needs a routine screening colonoscopy. I still send all my patients to them because I know that they're accepting and understanding and have a good bedside manner and are non-judgmental. And I work with a number of counselors. There's a couple in my area that I've talked to and worked with. Because of the pandemic, the burden on mental health providers has been really high. Obviously, a lot of people who are putting off counseling or who didn't, have the time or ability to commute to a counseling appointment, they can now do it virtually. So I think a lot of counselors are really full, and some of my favorites actually aren't accepting new patients right now, which is unfortunate. But we're lucky in the Pacific Northwest, and in the Seattle area specifically, we have Seattle Counseling Center, which was founded in 1969 and has been doing gender work since the beginning. So that's a really good resource for my patients, as well as multiple other providers in the area. So, I mean, it's pretty lucky out here. And it's one of the reasons why I do stay, despite the high cost of living, I do stay really close to the city of Seattle, is because there's a lot of resources out there for my queer patients and my transgender patients.
Do your patients use their insurances to see your colorectal specialist, or to go to your mental health resource providers, or do those providers accept cash pay?
There's a mix. There's a mix of it. I think for many of the specialists, there aren't a lot of independent practice specialists. So most of them are hospital affiliated, they offer colonoscopies, they use the procedure area that's in this hospital. And so there's a facility fee and so on and so forth. So it's not really financially, it's quite costly to pay out of pocket for some of those consults. So I would say, so looking down at before our call, I took a peek at my demographics, and I'd say a majority of my patients do have insurance. Not all of them by any means. I have quite a number of patients that don't, but they do choose to use insurance for most of their specialty care. For counseling, so there's for health insurance, usually there's a good kind of parity plan where if they cover regular doctor's visits, they'll also cover counseling, very similar copay. If not, there are some cash pay counseling services or sliding scale. There's online services that have similar type memberships, like BetterHelp.com. I think you pay a weekly or monthly fee. So there's a lot of payment options, just depending on the specialty. I mean, obviously, if somebody needs chemotherapy and they need to see an oncologist, I do encourage most of my patients to have some sort of at least catastrophic type plan, because health issues and accidents, I mean, they're unpredictable, right? That's why they're called accidents and not on purposes. So we, can't necessarily always predict or know when stuff like that's going to happen. So you want to be prepared. But yeah, so they don't use their insurance for my services. They can use their insurance for like with most DPC, they can use your insurances for their insurance for labs or imaging or medications. I don't dispense injectable hormones from my office. I definitely don't dispense testosterone. It's a controlled substance, or any controlled substances from my office for that matter. But I can get some medications at lower costs, or people can use online coupons like GoodRx. And then for labs, my labs are so affordable and so competitive that most of my patients, even those with insurance, choose to pay the cash rates, with the exception of my patients who are on Medicaid, which will cover labs 100%. So I usually advise they use their Medicaid for that. And I do have I think of all the insurance types my patients have, I do think Medicaid is actually one of the more common insurance plans. I do see a lot of people who meet the criteria for Medicaid and manage to still pay a monthly membership because the kind of care they get from my office is worth it for them.
In your area, you're closer to Seattle, you're closer to major medical centers. Do you see an issue with regards to a quick turnaround in terms of seeing a specialist?
It depends on the acuity. So I have an uninsured patient who had a chemical burn, and I was able to reach an on-call fellow for one of the major burn clinic, the major burn center, Harborview here in Washington, and kind of get a direct line, and they called the patient directly and got her in within a couple of days. So for something like that, I think I can usually try to finagle something. Having a large academic center of University of Washington and multiple residency programs in the area, I think there's a lot of options. But let's say I have a patient who's had this dermatological condition, let's say, and we've tried this, we've tried that, we've looked into this, we've done the blood work, we can't really figure it out. They need to see dermatologists. It's not emergent, but it's been going on a while. We really would like to get taken care of. It can be a wait. And Medicaid or not, it doesn't matter what kind of insurance, it can be a long wait. Now, if they do see a private practice dermatologist, they can get in a little sooner, but then they'd have to be in network, and not all practitioners take Medicaid. Washington, I think, has, as far as the states I've worked in, and I do think Washington has a pretty decent Medicaid plan. It's not perfect by any means, and sometimes their formularies just make me want to slam my head against the wall. But they will cover specialty care if needed, and if there's no specialist at their preferred hospital, they'll often agree to cover one somewhere else. Like, for example, I had a patient who was on Medicaid who had cystic fibrosis and had to have gender affirming surgery, and which would normally be done in an outpatient center, the kind of surgery this patient was having. But because of the cystic fibrosis, needed to have it in hospital, and the insurance approved the surgeon, but the surgeon had privileges at an unapproved hospital. So the surgeon's fee would be covered, but the facility fee, the anesthesiologist, the nurse anesthetist, anybody else who's working on the patient in the hospital, and the hospital stay itself, if there had to be one, wouldn't have been covered. And so I had to do a lot of paperwork, but eventually we got it to happen, which was a really good thing for that patient. So yeah, I think I wouldn't say I see necessarily more barriers for Medicaid patients than I do for other insured patients. I have mostly Medicaid patients, so I have kind of a bias there, but I think everybody experiences very similar barriers. There are a few of my patients do have insurance, they can self-refer, and they definitely have an easier time of that, but they're such a minority. That's not something I encounter very often.
For situations like you described with regards to the doctor's fee being covered, but not the surgical side, do you have patients who are using health sharing plans? And is there a particular plan that is more sensitive to gender needs and gender issues?
No. I think if you talk about like the health share ministries and such, their coverage is so arbitrary that I would even insurance plans that guarantee coverage for gender affirming care, there's still barriers and struggles that we have to go through. So we have different kind of versions of Medicaid, and I have a patient who's on one who's adolescent and is in kind of the mid stages of puberty, and we wanted to use a puberty blocker before we started cross-sex hormones. And it was probably 8 or 9 months before we got that approved, even though it was a covered benefit the medication we prescribed was on formulary, just the hoops we had to jump through to get that. I can't imagine a health share would be any easier. I've seen them deny perfectly reasonable, non-controversial claims. A lot of these health shares are based in Christian ministries, and I think some of them explicitly state that they don't support anything that goes against their quote unquote Christian principles. So they could, some don't cover any reproductive health, whether it be birth control or IVF, or some don't cover mental health at all. So I'm not a huge fan of the health shares because of that. I know that there's a few newer ones out there that claim to have kind of more broader coverage. I don't have any patients who are on those. And I actually have there's a insurance broker who's about 3 doors down from me in my building. And she and I usually, if I have a patient who's completely uninsured, but would qualify for something either under the Washington, health plan finder or straight up Medicaid, she can help us find something that works, that's cost effective, and that may actually include some of their, favorite specialists. If there's a health share out there that specifically will call out that they do cover gender affirming care, I would love to talk to them. I'd love to work with them and see what they could do for my patients, especially those who are, uninsured.
You mentioned there are multiple residencies around you, and you are working with the University of Washington specifically and attending for the LGBTQ Pathways elective. Can you share about what that is, please?
Yeah. So the medical students can choose pathways at UW based on certain interests. And usually those who choose to go into family medicine, internal medicine, psychiatry, or, OBGYN can choose the LGBTQ Pathways elective. My role in that is I'm a clinical site that they rotate at. So they come to work in my office, to see patients with me, and to kind of see my approach to patient care. Right now, the way the elective is structured, when they're seeing me, they see me 1 day a week and they go to a different site every other day of the week. And then that rotation's for a month. So I end up seeing the same student every Thursday for a month. So it's only really 4 times that they're there. But I really enjoy being a clinical site because my practice is so different than anything they've ever seen. And it's always really fun for me to kind of show them, and you can do it like this. I draw my own blood. I do small office procedures. I do televisits and in-person visits. I see entire families. I think they get a lot of hands-on experience and what it's like to be kind of an old school family doctor when they come to my office. And I don't think they get a lot of opportunity to have those experiences otherwise. So I really enjoy that. And in most clinical structures where you have a medical student, and the medical student, when I worked with students a lot in my old practice as well, the medical student goes in, takes the history, does the relevant exam, comes back out, presents to the attending, presents their plan to the attending. Then the attending goes back in with the med student, repeats the important parts of the history, repeats the important parts of the exam, goes over the plan, either with the student in the room or steps out and tells the student, that's a fine plan, go ahead and tell the patient, right? So it's this kind of hierarchical approach, right, to teaching. In my practice, that's just not, logistically is silly. I have a 160 square foot office. I have another room that my MA kind of spends the day in, and that can also serve as a waiting room if my patients have to wait or have family members, that aren't part of the visit. So not being in there with the student is silly. So I sit there, we do the visit together. So I tell the med student, you're running the visit, but I may interject, and you're welcome to interrupt me as much as you need to, and kind of run the visit kind of tag team. But I try to let the student run the show. If we draw blood, I often let the student draw blood. And most of my patients are surprised that med students don't really learn how to draw blood. So I get to work with them on that. And we do our own lab samples and spin down the blood for processing, and do all these steps that normally they wouldn't see, right? They'd send the patient to the lab for those kinds of things. They also get more time. So I know I had a new patient come in for a new visit, establishing care, and we had a 90-minute visit with the med student, and it was great. And we got everything we really felt like we needed to do. And the patient had, and by the way, and we did a cursory exam. We're like, oh, geez, your ear canals are blocked. So then, okay, well, we'll rinse out your ears. And we could do a little bit of everything. It wasn't like, okay, well, we'll get you back for A, B, and C. Right. And I don't know if they've ever seen that either. So it's a pretty cool opportunity to show them how to do that.
I ask many people about how to affect the pipeline. And I think that's the most effective way, is to have a person see what you do and to do what you do, because talking about it does not make the same impact as like you're doing a thoracentesis in the middle of a clinic where you just took out a cyst. It's just, I can picture the medical students in your practice having that sense of, oh my goodness, she's literally doing that right here in front of me and I'm helping. So,
yeah.
Incredible.
Yeah, we had a patient who I have patients come in for injection teaching if they're on injectable hormones. And I think one of the things that happens a lot is like a division of labor, which I think has kind of created its own need for itself. The nurses do X, the doctors do Y kind of thing. And in my practice, we don't have nurses, so I do it all. And I think there's no reason why we can't teach a patient how to give themselves a shot. I mean, that's normally something that we defer to the nurse so that we could see the next person that's sitting in the room next door, right? So I can move through, see as many people as possible. So I like that my students have been able to have that opportunity, and I do what's relevant. So I don't treat a patient for the chart or for billing purposes. So a lot of times, well, all of the time, when you see somebody in a conventional system, they have to check these certain checkboxes off to make it a billable visit. And if it has to be billed a certain level, it needs these certain things met. And so they kind of become a part of your workflow. Like you ask these 2 questions, even though they might not be relevant, because then you can put it in the chart and then you can bill it up one, right? As a 99214 instead of 99213, because you ask these 2 review of systems questions that you normally wouldn't ask. So in my practice, since I don't bill insurance, none of that is necessary. You don't have to, we treat what the patient is there for and what's specifically relevant for the patient. And that's actually a struggle sometimes for students. And I encourage them to kind of start really wide and then learn to narrow, because that's always the kind of the best way to approach medicine. So you don't, it's harder to kind of broaden your view. It's always easier to narrow your view. So I try to let them keep their view as broad as possible. So they may ask a million questions about something that I would know isn't specifically relevant, but they're not sure yet. So they can ask that. But I don't make them like do any chart plot. And I don't have to repeat all the portions of the history because I'm right there next to them. We don't have to worry about whether or not the insurance is going to pay us because the doctor didn't also ask when the symptoms started. Like I was sitting, we were all there when we asked the symptoms are started. We got the answer we needed. Patients getting the care they need. It's not about the chart. It's not about insurance. But it's a very unusual sensation for students too. Like they're not used to that. It definitely makes them feel they have more autonomy because everything's not getting done twice for billing.
And when you compare that to the paternalistic system that you described earlier, you've created a safe space for your patients, and now you've created a safe space for your medical students as well.
Yeah. It's nice. I do enjoy working with the students, and they chose the LGBTQ pathway. So they're there by choice, and they're there specifically to learn more about seeing queer and trans patients. And so I do try to kind of, if I have the option, try to book more patients that are queer and trans on the days I work with med students. But I think they get a lot out of rotating with me either way because of the structure of the practice. There's a lot to get out of that too.
Now, how do you manage the med students coming into the visits with your patients? Meaning, do you have the patient sign like it's okay that a medical student come in with you? How do you handle that?
Yeah, I think when a patient signs up, when I explain how my practice works, explain what days I'm open and, how sometimes I might have late hours or coming on a weekend, but that's not like there's no regular occurrence for those things. And I always say, and I also, I work with medical students on Thursday. So if you come in on Thursday, there'll be a medical student with me. If that's not okay with you, we can always book you on a different day, or the med student can step out. So I give the patients an option. And for patients who are trans or who are going through a transition and at kind of a more vulnerable stage of their transition, I also will say this student is here to learn more about taking care of patients just like you. Would it be okay that they take part of the visit with me? I'll be here the whole time, kind of thing. So again, it goes back to trust. Like I I like to think that I have trust with my patients. So when I say, hey, this other person's okay, they trust me. And I'm not going to violate that trust, but I'm also going to give them the option. Like I've definitely had instances where they're like, actually, no, I'd rather not. And so I said, okay, go down to the coffee shop in my building, go to the coffee shop. I'll text you when we're done. But yeah, it's pretty straightforward working with students. I think a lot of people who are familiar with the healthcare system know that somebody has to learn. And I think that they appreciate that these people are learning for someone who kind of creates this welcoming environment. And hopefully these students will have the kind of trust with their patients that I do too.
Definitely. Most patients, as long as they're aware that they can choose to have a medical student or not, it's only been a handful of patients I've seen who are adamantly against medical students.
Yeah. Like if somebody comes in and they're like, I have this weird rash down there and they don't want anybody else to see it, they're already a little uncomfortable. That's totally fine. I never pressure my patients to work with the med student. I mean, I certainly hope they don't think I'm pressuring them to do that. I try to make it really clear that it's absolutely optional. I feel like I have a lot to offer the students that rotate with me. They don't, necessarily have to put their hands on everybody to make it worth their while. So
I do appreciate the patients though, who are like, oh, definitely bring them in. Come on, let's meet him. Like,
yeah,
they're so proud to be
oh yeah,
person who is going to help this person be
especially when my students draw blood for the first time in the office. I thank my patients profusely, and then they're so great. I love my patients so much. They're so great. Like the other day, a student did her first blood draw on an actual person on my patient. My patient said, that was really great. I didn't feel a thing. And my student is just glowing, right? Just really kind of lifting them up. And that kind of thing doesn't happen as often in a regular practice because the environment of my clinic, and it's part of it's me too. I mean, it's not just DPC, but I'm much more kind of friendly, and I don't know if casual is quite the term. I mean, I wear sneakers and flannel shirts, so I guess I'm casual. But I mean, I try to make it welcoming. It's like going to a friend's house who's a doctor who's helping you out. Like it's not meant to be very detached and very cut and dry. And I think it helps people be themselves and be happy and comfortable and open up and be open to new experiences, like letting a med student draw their blood. And it's great. I would never go back. So I do want to mention, so I do have a couple other irons in the fire, so to speak. I work for an employee health clinic for Seattle Cancer Care Alliance and Fred Hutchinson, which is a major research center in Seattle. And I work there occasionally. A friend of mine who I met through my last job, she was a float at with my last employer. She's kind of the head of that clinic. She's a physician who runs it. And when she needs a day off or is gone for the day to go teach or has a family event, I cover for her. So it's not a regular gig per se, but it's something I can do on the side. And it does help supplement my income so I can pay my bills. And then the other thing I do is I am a supervising physician for a physician assistant at a clinic called Healthy Transitions that actually operates out of New Jersey, New York, but I only help with the New Jersey side of things. There's another supervising physician for New York. And this clinic's been around for a long time. And in fact, the woman that I supervise actually has decades of experience on me. She's been doing trans medicine for so long, and she's published all over the place. She's the president of the American Physicians Assistants Organization. She's been AMA boards. I mean, she's just an incredible woman, and to be working with her is just an honor. And I don't do it for the money. I don't get paid very much for that. And I don't depend on that income. It's just a chance to help out a friend, but also to kind of keep my feet wet with somebody who's definitely always on the cutting edge of gender affirming care. So we talk on the phone and we do talk about cases, and it's just really valuable for me. So I really enjoy that. But the main reason for me bringing that up is that I have these, and I for a while I also worked for Teladoc, which is a televisit organization that contracts with insurance plans for patients to call all day, any hours of the day or night. And I definitely would work for them during the holidays. I would take phone calls for them. And then during the early days of the pandemic, especially since I'm licensed in New Jersey, and then here in Washington, I did a lot of calls about COVID, just people calling with concerns or symptoms and advice, and spent a lot of time on the phone. I haven't really done it since then, and I don't really plan to do that much more. I do these things because my business is growing slowly, and I'm in a very high cost of living part of the country, and I have rent to pay and groceries, student loans I'm still paying. So I need to supplement my income because I'm not making quite enough from my DPC practice to cover everything. I do pay my medical assistant. So I pay my medical assistant first before I pay myself. And if these side gigs don't work out, if I'm not making, I still won't go back. Like I just can't do it. I feel like in those cop shows, those prisoners are like, I'm never going back to prison. You won't take me alive. I kind of feel that way about corporate medicine. I can't imagine ever voluntarily going back to that system. And, I hear people saying, oh, well, if you work in this system, it's like this, or in this system, it's like that. And they take very good care of us. But if you look deeper, if you scratch below the surface, they're all very similar. Whether they're a major HMO organization or a Catholic organization or a community-based hospital, they all really use the same metrics and the same RVU system and the same process for their primary care providers. And I'll never do it. You can't make me. I'll never go back voluntarily. I'd rather struggle and be happy. So my father jokes that I'm the poorest and happiest doctor he's ever known. So, and I'd rather be like that than be making the big bucks and selling my soul every day.
So powerful, especially for the crowd of people who choose to listen to this podcast. It can give people hope if they are floundering right now and are in that situation that you were previously in. But it can also, those words can open the eyes of somebody who has not yet experienced that.
And I hope to make enough money from I plan to make enough money from my practice to not need any extra income on the side. That's the plan. And, I'm not by any means at the patient panel goal that I've set for myself yet. So I'm still growing, and I hope to grow. I schedule myself to make some big moves in terms of growth after being open for 6 months. But that was around the time that I started going through a divorce. So that didn't happen. So I gave myself some time. It's my business, right? So I can slow it down and do what I need to do. And then I said, okay, 2020, I'm going to really push. I'm going to market. I'm going to get out there. I'm going to talk to some businesses and see if their employees want to sign up. I'm gonna really make a big push and grow my practice. But then the pandemic hit, and I felt like a shark. I didn't want to go out there and sniff around for blood and get patients under duress. So I didn't want to do any marketing. It just felt gauche. It wasn't appropriate to. So I let people know whether or not you have insurance, you can see me. So when people are losing their jobs and losing their insurance, I'm still can be your doctor. And actually during that time, I had a few patients reach out to me and say, I've lost my job. I don't know if I can afford this anymore. So I reached out to my patients and I said, let me know. I said, some of us live hand to mouth or paycheck to paycheck, like in the best of times. And it's not good times right now. So if you can't afford it, please let me know. Just reach out to me before you cancel. And if you can afford it and you can afford any extra, let me know. And maybe we can use that money to help out other folks. Well, the response I get was amazing. I was actually I was covering for the doctor at the employee health clinic at the Seattle Cancer Care Alliance at the time after I sent that email out that morning. And I started getting all these emails like, where do I send the check? How much money? Can you just charge my card this much extra for people? And within the week, I had enough people volunteering to pay for other people's memberships that everyone was covered. Everybody could stay. Nobody had to leave because they lost their jobs or they couldn't afford it. So 2020, I grew a bit, surprisingly, but I didn't grow like I had intended to. So I'm hoping to do some extra work to grow this year in terms of my patient panel and getting more people kind of signed up, and we'll see how that goes.
What strategies are you looking to grow your practice this year?
Well, I am looking to do a little bit on the social media networks. So like Facebook ads, maybe posting some things on Nextdoor. I did get a patient. I created an account on there, and I did have a patient kind of find me through there at one point. So I think that might be a useful resource. I know some docs have like issued press releases and gotten some like free press coverage, which has been really helpful. That's something that people talk about a lot when they talk about their private practices. So DPC isn't really a new concept in the Seattle area. We had Garrison, you interviewed Garrison Bliss already, but we had Q Lions here for some time. And so it's not a new concept per se. So I wouldn't say it was necessarily newsworthy. And I'm not really big on self-promotion. So I haven't really reached out and been like, look at me, I'm doing this amazing thing. You want to write a story about me? But I have some patients who feel that way. So I actually have a patient who's interested in trying to get like a press release out and see if anybody would be interested in kind of learning more about my practice and maybe getting word out locally about what's going on. And then I'm hoping to reach out to some employers and to make sure that they know that this is an option. Ironically, I have a couple employers, but the first employer that I ever onboarded for their employees was ironically a medical collections agency. So, which always makes me laugh. So that the people calling patients to collect money that they're not paying for their bills are going to DPC for their primary care. So it's just kind of interesting. But yeah, I'd like to talk to some more employers and see if they want to, get their folks on board. And then obviously reach out to the queer community. I've been doing a lot of outreach. Unfortunately, I don't know what's going to be happening in person. So, a booth at Pride would be really great, but I don't think there's going to be booths at Pride this year. Sponsorships, sponsoring maybe some events, doing some local talks, like PSAs, doing what I can to just kind of be engaged with the community, both the queer community and the community of Renton, where my practice is located. I think those will be a couple of things I'm going to do. Marketing, I would say marketing is not my strong suit, but I am very good at helping rally other people to help. So my MA is really interested in helping with marketing. I told you I had a patient who's really interested. So yeah, hopefully I'll delegate as much of it as possible.
Liz, I want to ask you, because that shared, Tarina, your medical assistant, joined you just this year or just this past year, correct? And
yeah.
What led you to the decision of, yep, this is the time that I'm going to add Tarina onto my team?
I decided at the very beginning of 2020, I decided that I wanted to try to hire an assistant because I realized there were little things that were difficult for me to do, like returning phone calls. I was just having a hard time keeping up with that in addition to emails and texts. And especially if there were calls like from a pharmacy, just clarifying, like, did you want the ointment or the cream? So I thought, it'd be great. I could have an assistant. They can help with scanning was another thing that I just didn't like to do. And I was like, just somebody kind of part-time. So I hired actually a very young woman. I think she was in her early 20s. She was just 21 actually. And she kind of worked really more as an administrative assistant and just helped like kind of funnel emails and texts. And she did a lot of scanning and a lot of kind of working on all the different apps and online things that we use to run the business. And at the beginning, there wasn't a whole lot for her to do. And we kind of figured out, she kind of made the job into what she wanted to do. And she was with me probably starting in around February. So right around the time that we started looking into COVID, like pre-masking, I'd say. And she was with me through all of that. And she was incredibly valuable. She helped. Scheduling is one of the things I needed a lot of help with as well, since I have a kind of a dual scheduling system that's a little complex, but it allows my patients to schedule themselves. So I maintain that. And she was just great. She was so valuable. And I kept telling her, I'm like, I don't know what I would do without you. And then one day in August, she said, I have to give you my notice because I'm doing this and going to school is going to be a little too hard because she was going back to school. So she left and I knew immediately I have to hire somebody else. And I was looking at, folks, and I had a couple people lined up. I actually offered the job to somebody who then, just as I was like getting her onboarded, got another job offer. So I ended up declining. And I got this email from Tarina and started to talk to her on Zoom and checked her references. And it just looked like it was going to be a good fit. And she's great. And she's an MA. So she's much, more medically qualified than my previous assistant. And she's able to help, like she can take blood pressure, she can draw blood on somebody while I'm filling out the lab form or vice versa. So she's been, I always tell her, I'm like, she's the best thing that happened to me in 2020. So yeah, so I hired her, I think around November, sometime before Thanksgiving, and she's been with me since. And she's one of the faces of the practice, and she has the work phone. So when people call, she's the one they talk to first.
Very cool. Now, this is something I saw it on your website, but when you speak about equal care for marginalized patients, one of the things that you had on your website was UserWay. How did you come to find about that? And can you share about how UserWay's helped your practice?
So I don't think it's made any changes to my practice, but I think it's the responsible thing to do. UserWay makes web material more accessible to people with, disabilities. So dyslexia or, visual impairment, et cetera. It's actually a legal requirement. So it's not UserWay specifically, but having some sort of accessibility. So for those who don't have something like that, I encourage them to look into it. UserWay is free. It's easy. It's a nonprofit. I believe I made a donation when I initially signed up to use them, but I don't think it was required. And I actually found out about it from a patient of mine who's a web developer. She said, you know what, you're missing an accessibility widget. And that's all that I needed to say. So I learned it from a patient. So great. That's why family medicine is wonderful. I mean, I learn about health, I have a patient come in and says, I have this health condition. And I'm like, wow, I think I remember that from med school, but haven't seen it since. And I learned. And then I become much more, well-versed in that condition because of my patient. And it works all ways. I learned about website accessibility from a patient of mine. So yeah, so I encourage people to, if they do go to my website, if you click on, it's a little person in a circle. If you click on that, there is a way to link to kind of UserWay itself so that you can learn more about what they are and what services they provide.
I played around with it on your website, and your website was the very first place I'd ever seen it. And I thought it was absolutely fantastic because it is a very patient-friendly, accessible way to address patients with disabilities of different sorts.
Yeah. And it's as a physician, right? And my goal is to take care of all my patients, regardless of whether they're dyslexic or have visual impairment or English isn't their first language. I can't discriminate in the office. I can't discriminate on the website. I refuse to. So I'm happy to be able to offer that to my patients or to anybody who just wants to read about my mom or visit my website.
Now, Liz, after hearing your story and what you've shared, if a doctor is wanting to learn more about best practices in LGBTQ medicine or good resources to know about in case they have questions, what are some resources that you could recommend?
There's a lot of really good, really valid resources out there. The World Professional Association for Transgender Health, or WPATH, is an international organization that is focused on the healthcare of transgender and gender non-binary patients. And the reason why that's such a useful resource is that a lot of the research and evidence that we use when we treat transgender individuals specifically and do gender affirming medical care has been done in Europe because there have been a lot of restrictions in the US in terms of funding for research for transgender individuals, and also clearly a lot of stigma. So people don't identify as often or used to not identify as often in the US as gender nonconforming. So European research is very important part of data that we use to make our medical decisions, to make really evidence-based medical decisions. So WPATH is excellent. They have a journal. They have classes you can sign up for. They even have, I think, their own certificate program. So you can be kind of like certified WPATH provider. So they have a lot of resources for people in all sorts of places in the medical industry. So whether you're a speech pathologist or a licensed mental health counselor or a physician, or a surgeon, they have resources. That would be the first resource I would recommend. And then locally or on a national level, the UCSF, UC San Francisco, has guidelines on transgender health, really spearheaded by Dr. Maddie Deutsch, who is a really prominent healthcare provider who's been providing gender affirming care for quite a long time, and who I personally know from my affiliation with the Gay and Lesbian Medical Association. She has a very easy to access, easily indexed, free online resource on how to provide evidence-based care to transgender patients. And a question I get a lot is, what is there evidence for? Like, what do we do if there's not evidence for this? Those things are discussed. So there's discussion on the use of progesterone for trans feminine patients, discussion on birth control for transmasculine patients on testosterone who no longer have menses but still have a uterus. There's discussion breast cancer screening for trans women, voice therapy, all sorts of things just easily indexed at UCSF. So those are the two places I would start. There's a lot of other resources out there. There's resources, lifestyle things like chest binding or tucking, which are things people do to help pass. So there's stuff on passing. There's busy online forums for people who are really socially isolated and don't know any other trans people, for them to meet and talk to other people going through the similar stages that they're going through. So there's a lot of resources out there, but I would say for other doctors or people who are very kind of scientifically minded and really are looking into the evidence in treating transgender patients, that's where I would start.
Fantastic. And in terms of contacting you, what is the best way for others to reach out if they would like to ask your opinion or if they have questions?
Yeah, they can go to my website, so oodlemd.com, or they can email me at, the shortest email they can email is doctor@oodlemd.com. So that's doctor@oodlemd.com. They can just email me. I get emails all the time. And I always tell people, if you don't hear back from me in a reasonable time, then email me again, because might end up in the spam folder at the bottom of a list. Patients come first before curbside consults. But yeah, I'm more than happy to talk to anybody. They can go to my website and look. I have all my contact information on there, my email, phone number, my office mailing address. And I'm just more than happy to help people out whenever they have any questions. And I do often. People I went to residency with or who have seen me speak at one time or another, they'll reach out to me occasionally, and I'm more than happy to help them out. So I'm not the end all be all expert on all things in transgender health, but if I don't know the answer, I might be able to know who I could point them to for that answer, or ask, somebody I know who would be the end all be all on that specific issue. I'm more than happy to help out.
Wonderful. Thank you so much, Dr. Eaman, for joining us today.
Next week, look forward to hearing from Dr. Nasser Mohammed of Ulsra Medical in San Francisco, California. Also, the AAFP DPC Summit registration is open at dpcsummit.org. The conference will be held virtually from July 16th to 18th, so register today. If you like what you heard today, please leave a review and subscribe wherever you listen to your podcasts. Tell your friends too. For more information on this episode and much more, please visit mydpcstory.com. Also, for the latest in DPC news, check out dpcnews.com. Until next week, this is Marielle Conception.